Assalamu alaikum everybody. I hope that you are in good health and prosperity. In continuation of our last talk about drug acting on the cardiovascular system, we start today inshallah talking about drug treatment of myocardial infarction, and we are going to talk about pathophysiology and the rationale behind the therapy of myocardial infarction. So the main goals of this lecture, we are going to know what are the different types of myocardial infarction, what are the complications which results from the acute attack of myocardial infarction, and we are going to speak as well about the rationale behind the therapy of myocardial infarction. We have spoke about last presentation, we talked about that ischemic heart disease is a disbalance between oxygen demand and oxygen supply to the heart muscle. This will result in two different types of ischemic heart disease. The first is known as angina pectoris, and the second is known as myocardial infarction. So what are the differences between angina pectoris and myocardial infarction? The first most important difference that angina pectoris involves ischemia, but there is no death to the myocardial tissue, so there is no infarction. So angina pectoris, there is ischemia, there is decrease in oxygen supply to the heart muscle, but this ischemia does not result in death of the myocyte or necrosis or infarction. So there is an ischemia but no infarction. On the other hand, myocardial infarction, ischemia will result in death of the myocyte and what's known as infarction. This is the first important difference. The second important difference usually that angina pectoris, there is no change in the cardiac enzymes. When we measure cardiac enzymes like troponin C, we find that there is no change in the cardiac enzymes. On the other hand, myocardial infarction is characterized by an increase of cardiac enzymes, which indicates that there is damage to the myocytes like troponin. Okay. Third, angina pectoris, usually the ECG electrocardiogram usually is normal. There is no change in the electrocardiogram. On the other hand, myocardial infarction, usually there is a change in the electrocardiogram or ECG. Okay, so these are the three major differences between angina pectoris and myocardial infarction. So now we'll speak about the myocardial infarction. What are the different types and the mechanisms involved, and what are the main complications? So first we'll talk about the different types of myocardial infarction. This information has been obtained from this article, which was published in 2018. So to differentiate, there are two major different types of myocardial infarction. This classification is made according to the condition of the coronary arteries. The first type is known as type 1 myocardial infarction, and usually this involves atherosclerosis of the coronary artery, as we have explained last week, plus thrombosis or formation of a thrombus in the coronary artery. Okay, a type 1 myocardial infarction, there are two different types. The first type, where there is a rupture of the coronary plaque, of the atherosclerotic plaque, there is a rupture. Part of the atherosclerotic plaque will be broken, and this will stimulate coagulation factor, and this will result in the formation of a thrombus which completely block the blood flow. There is complete block of the coronary artery. This will produce specific changes in the electrocardiogram with ST elevation. ST segment of the electrocardiogram will be elevated. That's why this type of myocardial infarction is known as ST, elevated myocardial infarction, or STEMI. STEMI is abbreviation of the ST, elevated myocardial infarction. So this is the first type of type 1 myocardial infarction. A second type, where there is atherosclerosis and rupture or erosion of the atherosclerotic plaque, which will result in formation of a thrombus which does not completely block the coronary artery. So there is an obstruction of blood flow, and this obstruction of blood flow is long enough to produce ischemia and necrosis of the myocardial tissue. Okay, this usually there is no elevation of the ST segment of the electrocardiogram, and that's why it is known as NSTEMI, non-ST elevated myocardial infarction, non-ST elevated myocardial infarction, or NSTEMI. Okay, so in this case there is no elevation of the ST segment in the electrocardiogram. On the contrary, there is a depression of the ST segment, not elevation, there is a depression, or there is a T wave inversion, where there is inversion of the T wave. Okay, so either possibility will take place in the electrocardiogram. So this is type 1 myocardial infarction, where there is atherosclerosis plus thrombus which partially block the coronary artery, and this will produce NSTEMI, or non-ST elevated myocardial infarction according to the electrocardiogram, or it will produce, if there is a complete block of the coronary artery, will produce STEMI. In both cases, type 1 myocardial infarction, there is an increase levels of troponin in the blood, which is the cardiac enzyme marker. So there is high troponin level, whether it is in STEMI, ST elevated myocardial infarction, or the non-ST elevated myocardial infarction. So this is the first type, type 1 myocardial infarction. There is another type which is known as type 2 myocardial infarction. Usually type 2 myocardial infarction, there is no thrombus. There might be atherosclerosis, but there is no thrombus. So what will happen in type 2? In type 2, usually the demand is more than a supply for a long period of time. So supply is less than the demand for a long period of time, which will result in death of the myocyte. So type 2 myocardial infarction is due to mismatch between an oxygen supply and oxygen demand, as we have said. So there is usually less oxygen supply with higher demand. There are two conditions. The first is where there is atherosclerosis, as we will mention in a few minutes. There is atherosclerosis but without a thrombus. Atherosclerosis for a long period of time will result in less oxygen supply, which cannot meet the demand, and this will lead to chronic ischemia of the myocytes, and this will lead to infarction. This is one. A second, sometimes the myocardial infarction is triggered by underlying cause. Myocardial infarction is triggered by an underlying cause, is not due to atherosclerosis or thrombus, but there is another cause which triggers myocardial infarction. This includes cardiac causes related to the cardiac muscle. As example, formation of arrhythmia, whether it is bradyarrhythmia or tachyarrhythmia. In this case, arrhythmia means increased work of the heart, increasing oxygen demand. This is one. Plus, And arrhythmia will decrease the oxygen supply to the heart muscles because of the decrease in cardiac output. So any type of arrhythmia like a bradyarrhythmia and tachyarrhythmia can result in myocardial infarction type 2. Okay, this is one. Second, cardiac, when there is a valvular disease. When there is a valvular disease, a disease in the valves which result decrease in perfusion of the heart muscles with oxygen or blood, and this will result in myocardial infarction type 2. Also, cardiac hypertrophy, as we know, will increase the size of the cardiac muscle, will decrease the efficiency of the cardiac muscle, and decrease the efficiency of cardiac muscle, that means will decrease the oxygen supply, and this will result in long-term after long-term in myocardial infarction. Of course, acute heart failure will produce low cardiac output, and low cardiac output means low oxygen supply to the heart muscles, and this will result in myocardial infarction. Okay, so these are 4 different reasons where myocardial infarction can take place due to cardiac dysfunction, like arrhythmia, like valvular diseases, like cardiac hypertrophy, and acute heart failure. Sometimes myocardial infarction can result from an external factor, not cardiac factors. Like, for example, hypertensive crisis, when there is a severe increase in blood pressure, therefore that means a severe increase in peripheral resistance, that means a severe increase in oxygen demand by the heart because it has to work against high resistance, and this will result in cardiac ischemia and myocardial infarction. Also, the same thing if there is a shock, the opposite. If there is a very low blood pressure. Very low blood pressure means low oxygen supply to the heart muscle, and this will result in cardiac ischemia. Of course, respiratory failure plus severe anemia in both cases will decrease the oxygen supply to the heart muscles, as you know. And lastly, critical illnesses. If the patient is subjected to critical illnesses, usually critical illnesses will trigger myocardial infarction. Okay, so these are generally different type 2 myocardial infarction. Type 2 myocardial infarction, we said that there might be atherosclerosis but no thrombus, or might be due to other underlying causes. So there are 4 types of type 2 myocardial infarction. The first, as we have said, there is atherosclerosis, which is not complicated with a thrombus. This atherosclerosis, usually blood supply, usually the diameter of the coronary artery is so small that the blood supply to the heart muscle is low. Therefore, it will not meet the demand. Of course, if the demand is higher than the supply, especially on a long period, after a long time period, this will result in cardiac ischemia, and cardiac ischemia will result in myocardial infarction. This is first. Second, there might be irreversible spasm of the coronary artery for a long period of time. As we have said before, that there is difference between angina and myocardial infarction. In angina, there is one type of angina which we called vasospastic angina, or variant angina, or Prinzmetal angina, in which we said there is irreversible spasm of the coronary artery. In this case, in myocardial infarction, if the spasm is for a long period of time, this will result in ischemia for a long period of time, and this ischemia for a long period of time will result in infarction of the cardiac muscle or death of the cardiac muscle. So this is vasospasm or coronary microvascular dysfunction. So this supply will be less than the demand. Third type, when there is coronary dissection of the coronary wall. This dissection of the coronary wall will narrow the diameter of the coronary blood vessel, and of course this will result in lower blood supply, and this will result in myocardial infarction. Lastly, even as we have said, there are non-cardiac causes like chronic illnesses, like severe anemia, like respiratory failure, where the coronary artery is okay, but the supply is low because of other underlying causes which does not meet the demand. This will result in myocardial infarction. So these are the differences between different types of myocardial infarction. There are type 1 myocardial infarction where there is atherosclerosis plus thrombus, and type 2 myocardial infarction which might be due to atherosclerosis with no thrombus, or no atherosclerosis but other factors which result in decrease in the blood supply to the heart muscles. Okay, so what are the complications of myocardial infarction? What will happen after myocardial infarction? After the death of the myocyte, what will happen? Different things might happen. This is an information obtained from these websites. You can get this information from this website. So the first thing which can take place is an impairment of contractility, because losing a considerable fraction of the myocardial mass will impair contractility. This would result in different pathological outcomes. So the first thing which can take place, of course, is ventricular thrombus, formation of a thrombus inside the ventricle. If this thrombus moves, it will form an emboli, and this emboli, if it reaches cerebral blood vessels, it can lead to stroke. So one of the results or complication of myocardial infarction is formation of the stroke because of the embolism. Okay. A second, impairment of contractility means that there is decrease in cardiac output, and this decrease in cardiac output will result in congestive heart failure. As we know, congestive heart failure means the heart is not producing enough cardiac output to meet the body need. So in this case, impaired contractility can result in congestive heart failure. Of course, congestive heart failure means decrease in blood pressure, and decrease in blood pressure or hypotension will result in lower perfusion through the coronary artery, because as we have said, the coronary artery or myocardial muscles receives its supply through the coronary artery. Therefore, if the blood pressure is low, coronary artery perfusion will be low, and this will increase the chance of ischemia. Ischemia will become more, will increase the chance of ischemia. This will result in impaired contractility, will result in what's known as cardiogenic shock. Cardiogenic shock means lower blood pressure due to low cardiac output. Okay. So this is the first complication which can take place due to myocardial infarction. A second complication, as we know, if tissue death or necrosis takes place in the papillary muscles of the heart, if they are become dead or necrotic in this case, and mitral regurgitation will lead to congestive heart failure. Okay. So this is the second complication of myocardial infarction. A third complication, of course, when tissue becomes necrotic, the ventricular wall will become very thin, and this will result in ventricular wall rupture. This ventricular wall rupture can produce what's known as tamponade, will produce cardiac tamponade. Okay, so these are two major complications of the myocardial infarction. The third complication, as we know, the necrotic tissue will act as an ectopic focus, and this anectopic focus will produce disturbance in the electrical conduction and ectopic activity, and this ectopic activity will result in different types of arrhythmias, especially ventricular arrhythmias, which are very dangerous. Okay, so in this case, if disturbance in the electrical activity of the heart will lead to different types of arrhythmia. Lastly, of course, pericardial inflammation will result after myocardial infarction, and this will produce pericarditis, which is lethal. So these are the major complications of myocardial infarction: impairment of contractility, tissue necrosis, different types of arrhythmia, and pericarditis. Okay, so how we treat myocardial infarction? What are the rationale for pharmacological treatment of myocardial infarction? First, we have to deal with the underlying cause. The underlying cause. If the underlying cause, as we have said, is an imbalance between the oxygen supply and the oxygen demand, we have to improve the oxygen supply over the oxygen demand. How we do that? By two different mechanisms. First, by increasing the oxygen supply to the heart muscle, or decreasing the myocardial oxygen demand. So first, by increasing oxygen supply or decreasing the oxygen demand. How we can increase the oxygen supply? By using different types of drugs. Some of them we talked about them last presentation when we talked about angina, which are the nitrates and nitrites and calcium channel blocker and beta blockers, where we said that we can increase the oxygen supply by dilating the coronary arteries, by inhibiting the vasospasm, and this can be achieved by nitrates, which we talked about in last presentation, and also it can be achieved by calcium channel blockers, nifedipine-like drugs, اللي هم block calcium channels on the coronary artery. Second drugs are drugs which remove the thrombus. As we have said, thrombus, there is decrease in supply due to thrombus formation. Therefore, it is logic that we remove the thrombus by drugs which causes lysis or dissolving this thrombus. These are known as coronary thrombolysis, by using specific thrombolytic drugs, as we will speak about in a few minutes. Okay, so these are the second group. Third, we inhibit any further formation of the thrombus by using anticoagulants, drugs which prevent blood coagulation, and antiplatelet aggregation, drugs which prevent platelet aggregation. So like aspirin-like drugs, and as we will talk about in a few minutes. Okay, so in this way increase the oxygen supply by using different groups of drugs which dilate coronary artery or dissolve already formed thrombus or prevent the formation of a thrombus. Second, we can improve the balance between oxygen supply and oxygen demand by decreasing myocardial oxygen demand, as we have said. Of course, how we can do that? By decreasing cardiac function, as we have said that cardiac function, like heart rate, like muscle contraction, we need oxygen. The higher the cardiac function, the higher the oxygen demand. Therefore, if we can decrease the cardiac function, like heart rate and contraction, in this case, we can improve or decrease the oxygen demand. This can be achieved, as we have explained last presentation, by beta blockers and calcium channel blockers. Also, as we have explained in our last presentation, decreasing the afterload and decreasing the preload, we will decrease tension on the ventricular wall, and decreasing tension over the ventricular wall will result in decreasing in myocardial demand, myocardial oxygen demand. Okay, so by decreasing the afterload, as we have explained before, by using of vasodilators or like nitrates or nitrites, and decreasing the preload, decreasing the venous return, we decrease the tension on the ventricular wall, and this will result in decreasing the oxygen demand. Okay, so we talked about that in our last presentation. A second measurement or rational treatment of myocardial infarction is to use pain analgesics, because usually in myocardial infarction there is severe pain, very severe pain. So usually in this case we use opioids, which are known as morphine-like drugs, morphine-like drugs or opioids. So what will happen? Opioids, what they do, they reduce pain, as we will explain inshallah when we talk about morphine-like drugs. Plus, in these drugs, they can reduce anxiety. Usually myocardial infarction is accompanied by anxiety. So in this case, these drugs will reduce anxiety and therefore can decrease the oxygen demand by the heart muscle. Morphine-like drugs as well, they produce vasodilatation, peripheral vasodilatation. Therefore, they will decrease the afterload. They will decrease the afterload. So by decreasing the afterload, they will decrease the work of the heart, and therefore they will decrease the oxygen demand. So morphine-like drugs, they act through different mechanisms as analgesic to prevent pain, reducing anxiety, and decreasing the oxygen demand through decreasing the afterload. A third is to control the heart rhythm. It is very common that, as we have said, the complication of myocardial infarction is formation of arrhythmia, and therefore we have to suppress this already formed arrhythmia by drugs like lidocaine. Lidocaine is, as we will see later inshallah, when we talk about antiarrhythmic drugs, they are used to suppress arrhythmia, which is a complication of myocardial infarction. And also we prevent the formation of any further arrhythmia after recovery from MI by using beta blockers. As we know, beta blockers, they are antiarrhythmic. Therefore, beta blockers, they are very effective in preventing the development of arrhythmia after myocardial infarction. Lastly, we have to inhibit cardiac remodeling. It's known that myocardial infarction usually will result in cardiac remodeling. This cardiac remodeling can be inhibited by inhibiting sympathetic activity, because the sympathetic activity is responsible for the remodeling, وكذلك inhibiting angiotensin II, because angiotensin II is involved in cardiac remodeling. Therefore, we can inhibit the cardiac remodeling by using beta blockers and also by using angiotensin II, renin-angiotensin II antagonists like beta blockers by inhibiting renin, and by using converting enzyme inhibitors like captopril and its congress, lazinopril and etc., or by using the angiotensin II receptor antagonists. So these are the rational pharmacological treatment of myocardial infarction, which depends on four major steps. First, by improving the myocardial oxygen supply demand ratio and reducing pain, preventing or suppressing arrhythmia, and inhibiting cardiac remodeling. So in summary, we can say that myocardial infarction is of two types. Myocardial infarction type 1, in which there is atherosclerosis of the coronary artery complicated by a thrombus, and this type 1 might be either STEMI or non-STEMI. Type 2, usually there is a disturbance between oxygen supply and the demand, and it is usually triggered by either cardiac or non-cardiac factors. We talked about the complication myocardial infarction, which are life-threatening and can cause morbidity and high mortality, and we talked about arrhythmia, heart failure, stroke, and pericarditis as complication of myocardial infarction. We talked about the rationale of treatment of myocardial infarction, including improving myocardial oxygen supply demand ratio, treatment of pain, treatment and prevention the formation of arrhythmia, and as well preventing cardiac remodeling. So our next presentation will talk about drugs which are used in the treatment of myocardial infarction. Until then, I would like to thank you for your attention. Please don't forget to subscribe to my channel. I wish you all success, happiness and prosperity. Wassalamu alaikum wa rahmatullah wa barakatuh.